First trimester intrauterine pregnancy. Obstetrical sonographic examination in the first trimester may be performed either transabdominally or transvaginally, but transvaginal sonography typically yields higher resolution images. The most common indications include confirmation of intrauterine location and exclusion of ectopic implantation, identification of cardiac motion, estimation of gestational age, and evaluation of vaginal bleeding and/or pain. It may also be used to determine fetal number, evaluate coexistent pelvic pathology, and exclude molar pregnancy. In high-risk pregnancies, first trimester sonography may aid the search for significant fetal anomalies, assist with catheter manipulation during chorionic villus sampling, or measure nuchal translucency as a part of prenatal aneuploidy screening. The first three indications are discussed here. In the first trimester, the embryo and its supporting structures develop rapidly. Early in this progression, the human embryo and its associated yolk sac and amnion lie within the exocelomic cavity. The decidua is the endometrium that has undergone preparation for pregnancy. That at the implantation site is the decidua basalis and is the location of final placental development. The decidua overlying the embedded embryo is the decidua capsularis, and the remaining endometrial cavity is lined by decidua parietalis. A more advanced pregnancy is seen on the right. The amnion now envelops the enlarging embryo, while the yolk sac is less prominent. The exocelomic cavity will eventually be obliterated by the expanding amnion. The capsularis and parietalis will grow closer as the uterine cavity is eventually obliterated by the growing pregnancy. One of the earliest sonographic signs of intrauterine pregnancy is the gestational sac, which is an anechoic fluid collection that represents the exocelomic cavity. This lies more to one side of the endometrial stripe. With transvaginal sonography, it can be seen by 4.5 gestational weeks, and with maternal serum beta-human chorionic gonadotropin levels between 1,500 and 2,000 milli-international units per milliliter. The decidua can help to delineate this gestational sac. Specifically, two concentric echogenic rings surrounding a round or oval anechoic area is the double decidual sac sign. With this sign, the inner anechoic oval is the exocelomic cavity. The inner rim represents the decidua capsularis, and the outer rim represents the decidua parietalis. The anechoic ring between these reflects the compressed endometrial cavity. Although these decidual signs are informative, a gestational sac can be more confidently confirmed once a yolk sac is identified. The yolk sac is typically seen with a gestational sac at 5.5 weeks gestational age. Soon after appearance of a yolk sac, a 1 to 2 millimeter adjacent embryo can be seen at 5 to 6 weeks gestational age. At this early stage, a surrounding amnion is often not seen. In this cine clip, an early embryo is visible, and cardiac activity can be detected at 6 to 6.5 weeks gestation. A yolk sac is adjacent to the embryo. All of these structures lie within the exocelomic cavity. With further development, the amnion envelops the embryo, and the yolk sac diminishes in size relative to both these. The crown rump length is the most accurate biometric predictor of gestational age and should be recorded. If carefully performed, it has a variation of only 3 to 5 days in the first trimester. The crown rump measurement should be obtained in a sagittal plane and should not include either the yolk sac or a limb bud. In this cine clip of an 8-week embryo, again the amnion, yolk sac, and exocelomic cavity are identified. In addition to the uterus, the cervix is examined, and here the cervix and endocervical canal are seen. The posterior cul-de-sac is evaluated for fluid, which if present would appear black or anechoic. Also, the adnexa are methodically evaluated, and the presence, location, and size of adnexal masses should be recorded. Here, an ovary contains a 5 cm anechoic cyst, which may represent the corpus luteum.